From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
And a profound greeting to everyone. I'm Dr. Brian Sims. I'm one of the senior medical advisors with the National Association of State Mental Health Program Directors. And I want to welcome you to episode 240 of the Crisis Jam. We're going to be talking today from screening to safety using the Columbia protocols in crisis care. And we're honored to have with us Dr. Kelly Posner Gerstenhaber, who is going to be talking a little bit more later about this particular element. So welcome to everyone who is joining us. We are glad you are here. Let's move on with what we have for today. And before we get started with anything, just in the chat box, we want to open up that chat box to have you guys use it as much as possible. So share in the chat box where you're joining us from today. And next. All righty, and this is a reminder that it's easier than ever to get aboard with Crisis Jam. You can go to crisisjam.com. We're talking about shaping the future together in terms of crisis response. Next. And it's also to remind us that you can register and join in on these particular crisis jams, and you can also watch it on live stream and stay in the know with all of the different things. And here's some of the highlights that you can see with some of the stories that we've done in the past, and even giving you some forward pieces as far as what we've done. We had some incredible episodes. We also have a plethora of YouTubes that you can go to. Roughly, I heard maybe 4 to 5 years worth of episodes. So because this jam has been going on now for nearly 6 years. So let's go now to our breaking news. And I am honored to have with us an old colleague, somebody who's been a part of the Crisis Jam for quite a long time, our own Victor Armstrong, who's the Vice President for Health Equity and Engagement with the American Foundation for Suicide Prevention. And Vic, if you're on, if you can come on board and give us a few moments to talk a little bit about the Upright and connecting communities.
I am on. Thank you, Brian, so much. It is a pleasure to be here on the Crisis Jam today. And it's also a pleasure to share with you about the Upright. For anyone who's unfamiliar, first of all, with the American Foundation for Suicide Prevention, we are the nation's largest suicide prevention organization with 73 chapters across the United States. We have chapters in all 50 states, plus Washington, D.C. and Puerto Rico. We're also the nation's largest private funder of suicide prevention research. And as leaders in the suicide prevention space, we recognize the importance of access to suicide prevention resources, particularly for populations and communities who have historically lacked vital access and or who have experienced a disproportionate impact of suicide. And as many of you have heard me share, I believe that access is about more than having physical proximity to more of the same traditional resources. It's about having access to resources that are culturally relevant, that are relatable to the lived experience of the communities being served. And perhaps most importantly, it's about having resources that a community is going to be willing to utilize. And so with that in mind, AFSP is embarking on a health equity initiative in which we will use our resources, our relationships, and our position to catalyze both local and national efforts to address inequities in suicide prevention. And to address these challenges, AFSP recently launched what we're entitling the Upright. It's a collection of AFSP's resources, including our research programs, policy, and public education. So you would see things in that space, which would be a website. You'll see things in that space regarding our research grant priorities, both our health and mental health, both on health and mental health disparities, researchers from underrepresented backgrounds. You'll see references to our programs, like our Let's Save Lives programs for Black and African American communities, our Talk Saves Lives for the Latinx community, our Stronger Communities for the LGBTQ community. So you'll see all of those resources there, in addition to seeing our policy and advocacy priorities highlighted and our public education, things like our Seize the Awkward campaign. You'll be able to find recordings of our Strong Talk podcast there, and Elevating Voices, which is our Facebook Live event that highlights disproportionately impacted communities. And so our aim here is to advance health equity in suicide prevention, but the upright is also a way to illustrate our journey as we learn better how to partner with communities. It also provides an opportunity for us to talk about this work in a much more holistic way by broadening the definition of community and emphasizing the intersectionality and the multiple identities that are disproportionately impacted by suicide, including rural populations, individuals with disabilities and chronic health conditions, and those experiencing maternal or perinatal health conditions, as well as those vocation-specific communities that experience elevated risk of suicide, like the construction industry. So you'll see things there about our partnership with Bechtel in the construction industry around addressing the disproportionate impact of suicide in construction as a disproportionately impacted community. So creating the upright stems from research that tells us that developing suicide prevention strategies for underrepresented individuals needs to be anchored with the understanding that communities have unique lived experiences and they need to see their experiences and identities reflected in those resources. The Upright promotes resources that acknowledge the critical gaps in access and representation and cultural relevance in mental health by engaging direct input from the communities that we strive to support. And we believe the way to do this is to right size the way that suicide prevention engages communities, or rather than a top down approach where resources and services are created in a lab, as I like to refer to it, often without community input, let alone being community led, and then are superimposed upon communities. The upright instead emphasizes doing it the other way around. Communities know what they need and what will work for them, and they simply need to be allowed to lead. Thus, our tagline for the upright is connecting communities, driving change. And as part of the upright launch, AFSP is hosting the summit. Many of you may have already seen some things about this online, or you may have received an email invitation. But the summit is an online three-part series that brings together local and national experts who are connecting communities and driving change in the suicide prevention field. The idea of the initiative is to move the needle on health equity and suicide prevention by reframing and identifying health equity as a population health approach. And so, as we bring all these folks together, we want to encourage and facilitate support for communities to build their own suicide prevention programs with sustainability and transferability, as well as creating pathways to help community-based programs or community-informed programs that may want to become evidence-based programs but need the guidance and support to do that. And so I will lead and facilitate the conversations for these three webinars around health equity and suicide prevention at the summit. Each webinar will feature experts in the field who will discuss issues critical to access. We'll also spotlight a different community-based program that is showing measurable impact in suicide prevention. And by community-based, we literally mean programs that were developed within and by and for a community. The first webinar will occur on Tuesday, October 28th, 2 o'clock, from 2 to 4:15. The featured organization, Communal Life, will share how their program entitled Life is Precious was created, or a program that was created with and for the Latino Hispanic community, and how it's impacting mental health and suicide prevention in the lives of Latina adolescents and families. It will also feature a brief presentation by Dr. Sherry Malik, who will discuss the suicide prevention framework, Dr. Ruth Shim, who will discuss the health equity framework in suicide prevention, followed by Q&A led by Dr. Christine Moutier. Webinar 2.
Vic, I'm going to, because we want to make sure we get on to others, but I do want to thank you for giving us that overview and really looking forward to this upcoming event. So thank you for sharing that with us and continue to do the work that you're doing, man. It's just incredible. Thank you so much for everything. Can we move now into the next section on voices in crisis care? And we're going to bring in Stephen Parker. who is a behavioral health planner with Stantec. And Stephen, if you could just give us a couple of minutes to describe today for the Voices in Crisis Care.
Yeah, thank you very much for having me on. Stephen Parker, architect and behavioral health planner. I had a chance to listen in last week to Kim, Dr. Chuck, and Matthew, and I was kind of struck by the training to reinforce care culture. It's something we wanted to design for, so the built environment responds to how you are trained and can inform how you heal and not hinder the process of engaging clients and patients in a therapeutic alliance building relationship. So I was really struck by just reinforcing that through your training and how the role of how to avoid coercion, confinement, chemical and physical restraint needs to really come down to that sense of care culture that is crafted in these crisis environments. So I think that resonates with me to learn how to design for that and respond to what are the needs of the training of these individuals who are looking to help those in crisis. As someone who has a parent who's repeatedly been admitted for psychiatric needs in crisis and emergency departments. And, I really feel that it's incumbent upon us to advocate through all roles in the built environment, through care, through legislation and policy for those that can't advocate for themselves. So I was just really kind of struck with that sense of passion they had around crafting that care culture from a variety of disciplines and perspectives.
Well, Stephen, thank you so much, man. I think you wanted to go ahead with the video.
Yeah, so this is a video of a simulation workshop research at Texas A&M University. We were engaged with them last summer based on some processes using full-size mock-ups and generative AI to actually help build consensus around the design process for, in this case, a crisis unit for adolescents. And so you can see here I'm working my de-escalation skills, and though no one was hurt in the making of this particular video, you can see why we have very particular design standards around furniture and layout. But the mock-up's really helpful for, in the case of running simulations and not an active unit, that you can move things around, right? So you can hear from the providers who are in these different roles, hey, I want to open up the care desk. I want to lower a barrier. I want to move a door and have a better reaction time, response time. And how you lay out the furniture arrangement to create that milieu space, and what is the social interactions that you intend to have and might unintentionally have. And so moving these spaces around live during the simulations helps us to better understand design's role in an evidentiary way. We find that crisis environments are evolving very quickly, much like how quick this unit is being laid out. You're seeing units being popped up all over the country, and how to inform that with evidence-based design. Not simply better practices that we're learning anecdotally project to project, but how to actually aggregate data, run these simulations, and better patient outcomes, and the role of the built environment to really evolve design that helps defy stigma, right? So is that the front door is oriented a certain way? Is the fact that you put the seclusion room in a certain location, or that you don't have one at all if that's how your facility is run? How do you create spaces that actively create calm? And when we do debriefs with prescribers, with frontline technicians, and thankfully with the students that were all young people involved in this, gave a great perspective on adolescent crisis environments. We'll be doing this again later in the fall. So hopefully if you're going to the National Update for Behavioral Emergencies, you'll see our white paper being presented there.
Oh, incredible, Steve. Incredible. I'm sitting here looking at it and thinking AI and how much that's really moved the needle ahead. This sounds like a wonderful, wonderful association where you're really kind of putting the planning out there, but getting real input from individuals as far as how they see it and valuing that input in your design. So just so fascinating, man. Thank you so much, Steve, for that overview. And we are now going to move into our hot seat. And we have the honor and pleasure of having two famous individuals with us. We're going to have with us today our own representative, Senator Tina Orwell, and we're going to bring back Vic Armstrong. So we're going to pair up this powerful team to do our Q&A for the hot seat question for today. So thank you both for joining us for this. And it is so honored, Senator Orwell, to have you on there. You're such an advocate for everything that we are doing. Vic, welcome back, sir. We weren't finished with you yet. So on today's Crisis Jam swag, and we want to remind people again, it is about swag. There is now the Crisis Jam store where you can purchase all sorts of things. But when you come on this and you do this Crisis Jam, you will get a t-shirt or something of your choice. There'll be a code that will be given to you and you can order from the store directly from it. So let's get to our Crisis Jam swag for today. And today's question for you guys, the Native and Strong Lifeline logo was created by Coast Salish artist Jason LeClaire, and it represents 2 ears for listening and 1 heart for compassion. The question is, a third sacred element completes the design. And what is it? Is it a feather with a black tip and white body? Is it a bumblebee symbolizing community? Is it a hummingbird mid-flight? Or is it a salmon egg drifting in a stream? So I'll throw that out to both of you. You are welcome to go ahead and while you're doing it, I encourage everyone in the audience to go ahead and put your answers in. And if Senator Orwell or Vic, if either one of you would like to see those answers before giving, that is fine. We're doing this according to Who Wants to Be a Millionaire format. So any thoughts on these?
Well, one, I just have to say it's the most beautiful logo, and we're so proud of it in Washington. And I should know this like easily. And I was thinking, oh, of course, it's 2 ears and 1 heart. And now I'm thinking, what is that third element? So do you have any thoughts, Vic?
I was hoping that you were about to say, I know what the answer is. I would love to see what the audience has to say. I mean, I would be guessing. I have a guess, but I want to see what the audience has to say.
All right. Well, let's do that then. If we've compiled the polls,
yes,
we see now that a majority of them are favoring a feather with a black tip and white body.
Yes, that was my first thought too. What do you think, Vic?
That sounds good to me.
All righty. Well, let's move right ahead and see how we made out. Well, what we do know is that it's not a hummingbird in mid-flight. We also know that it's not a bumblebee symbolizing community and not a salmon egg drifting in a stream. So you are correct. You are all on board. It is a feather with black tip. So it's a feather signifies culture and identity, completing the message of listening with heart and honoring Indigenous strength. Well done, guys. Well done to our Crisis Jam participants out there in the audience world. Thank you all. So let's move now to our over and under. So we're going to keep you in on this. And the over and under, if you're not... I always have to wait for the Cookie Monster to finish crunching before we move on to anything else. But on the over and under, this will be given out as a question, and either one of you could make a choice as to who would like to give the first prediction, and the second person would then say whether or not that prediction is earlier or later than this. So if we get into the question itself, as soon as it gets posted, the BHR in St. Louis was a pioneer of high-tech mobile crisis-enabled crisis call centers. So in what year was the BHR founded? So what we can do is if one of you wants to shout out a year, we can go to the other one and they can choose what they would say, whether it's earlier than or later than that date.
Do you have a preference, Senator Orwell?
I think you should jump in first.
Okay. What year was BHR founded? I'm going to guess 1987.
Okay. And Senator Orwell, would it be earlier than 1987 or later than 1987?
I'm going to guess earlier.
Okay, earlier. So drum roll, please. And the answer is 1994. So later. But as we have said so many times before, you both really get value out of this. You can get your t-shirt, hat, or whatever piece of memorabilia you'd like. And our profound thanks for participating in the Q&A. Thank you both so much.
Thank you very much.
All righty. Okay, and we are now ready for our lead story.
Brian, before we move on, we do have Art from BHR on.
Oh, he is on. Okay, wonderful. Dr. Bart, I was wondering if you could just give us a quick minute or so overview of what you just heard, sir. Since you are the pioneer of all of this, Would love to just kind of get your perspective.
So, you want me to give you a brief, like a 1 minute review of BHR, how we got started,
Yes.
or yeah? So, I believe, and there are folks who've been around longer than me, but BHR may have been the first state-funded, statewide crisis system that had both mobile outreach available and crisis services by telephone. We in Missouri actually used Medicaid matching funds to create a statewide system in 1994. It was a regional system, so the system was broken up across regions, but I believe we were the first state in the country to have a statewide, state-funded 24/7 crisis system staffed by professional answerers with mobile outreach available. And it was a really cool. They also created a mental health coordinator system to support with the civil and voluntary detention processes, and that team was had some really cool functions as well. And so we were certainly, I know there were lots of mobile outreach services that existed before BHR, but I'm fairly comfortable we were the first one that was statewide to do that. And we've actually really believe in the importance of mobile outreach services. I started at BHR in 1998, and I sent myself on my first outreach.
Wow.
So not only did I take the phone call, but I dispatched myself. And those folks who've done phone work and mobile outreach will tell you that going out to someone's home and being there when in crisis is truly one of the most amazing things that you can do as a professional. And we sometimes hear people say, "Oh, we can always solve it over the phone. We don't need mobile outreach." And I'm like, "Oh my goodness, the capacity for mobile outreach to help people and keep people out of the hospital." Like at BHR, our mobile outreach team diverts over 92, 93% of those responses away from the hospital. We have an incredibly high diversion rate. And so
Wow.
we really do believe that provide services where they are, keep them out of the hospital when you can, and make sure they get connected with care. And so just very honored to be highlighted, and thank you all.
No, no, no. The honor's ours. Believe me, we thank you so much for these services, and we thank you for the existence of that, both historically, as far as moving ahead, how we're looking at crisis service centers across the nation. So thank you. We are now ready to move into the lead story for today. And we are honored to have with us Dr. Kelly Posner Gerstenhaber, who is professor of psychiatry at Columbia University and founder and director of the Columbia Lighthouse Project. She is a recipient of the Secretary of Defense Medal for Exceptional Service. And Mike Hogan, the actual architect of zero suicide in the U.S. President's Commission on Mental Health, had said that her work is equivalent to the discovery of a vaccine with the ability to prevent death on a massive scale. What such an honor. And Dr. Posner, I don't want to take away from anything else, so please proceed. And thank you for joining us today.
Now it's my honor, and this is I'm so grateful for this partnership. So you're going to bring up the slides and I can move them?
Oh, I'm sorry. I thought you wanted to share the slides yourself.
No, if you can share them and then I can move them.
Okay.
Thanks. Okay, so we are here to talk about from screening to safety, and I'm not sure why. There we go.
You should be able to control them now.
Oh.
Or not. One moment. My screen share failed. Okay, I've given you slide control.
Okay. So we're here to talk about the Columbia, which really is the global method of detection. And, national and global agencies have said for decades that the lack of a common method of detection was one of our major impediments to suicide prevention. Mike Hogan, who was mentioned, calls it the blood pressure cuff. And if you had more than one blood pressure cuff, your doctor wouldn't know what your blood pressure means as well as they should, nor would you. So, and the Federal Action Plan and many others, talk about how, of course, we need to do this. And in the Federal Action Plan, it says we need to improve our ability to monitor across region, state, and county levels. So again, the Columbia is what does this. And it's not just the method of detection, policy across all states and most nations. It's actually the method to help us make sense of what works and what doesn't, what interventions, what are our hotspots. You can see many, many studies. This is one example. It used it to identify cities in geographical areas with increased concentrations. And agencies, federal agencies and global agencies use it to help us figure out where we need to do better. So you can see the VA working with the Office of the Inspector General, Government Accountability Office, where do we need to do better with suicide risk screening? What are our gaps? And then in terms of making sense of what works and what doesn't, whatever population you're looking at, there are hundreds of studies in veterans. What are the risk factors? What are the interventions that work, from risk factors, to college students? And, hot off the presses, this is from the State Physician Health Monitoring Program. When we're talking about crisis care, we have to take care of the caretakers as well. So this is very interesting in terms of what the Columbia delivers, right? So this Physician Health Monitoring Program observed a decrease in suicide risk over 3 years of risk monitoring with the Columbia. And this was an alternative to formal disciplinary actions for people at risk. So again, helping us make sense of how to care for the caregivers, which I'm really going to get into more. Now, I said that the Columbia is policy across all 50 states, across the continuum of care. And state after state has said, we've lowered suicide because why? It's connecting the right people to the care they need. And if you look at those hexagons, they're not just the things you would typically think of. It's also full-on public health, parks, transportation, etc. And what happens is the Columbia is typically the method to optimize 988 referrals and response, improving crisis care delivery and coordination with 988. In addition, within legislative examples. So this is one example, like 98% of the time, the center was able to get folks who call 988 to a place of safety using the Columbia. So this is an example. I have the honor of having leadership from Connecticut on the phone today, but you'll see a lot of this, kind of what is cutting edge when it comes to across the continuum of care. And it's so important. We talked about needing a global method of communication and detection, but again, across that continuum, it's to enhance risk communication, which leads to quicker care delivery. So in Connecticut, the policeman has this little sticky pad, and then it connects to the next systems, and that increases quicker, care delivery. And so you can see what Connecticut has done for many, many, many years, and Andrea will talk more about that. And this is connected to legislation and policy. So for example, we know that getting the right people to crisis care is so important. And this is out of the Connecticut legislative policy, right? That, kids sit in ERs for hours and hours waiting to be seen that are not actually at imminent risk and would be better served by community resources. And what's happening with the Columbia is that it's really improving crisis stabilization. And this is all over the world. Yes. So what it's done in Connecticut with all police using that, it's actually reduced the level of force, because policemen don't have to fight with people who need to go to the hospital that didn't need to go to the hospital in the first place. And you're going to hear more about that in the roundtable. And this is all over the world, okay? Getting the right people to care. The C-SSRS Screening central to the success of the crisis response team intervention in Singapore. This was an interprofessional collaboration between the Singapore police force and the mental health helpline and the Institute of Health. What did it do? It reduced unnecessary ED visits. It created greater mental health awareness, increased number of referrals, and increased collaboration with the various stakeholders. And you'll see this across the continuum. This was a study out of Magellan. When EMTs used the Columbia, there was 66% increase in voluntary hospitalization. That's what we want, right? So the Columbia consistently aids crisis services in diverting people away from psychiatric hospitalization and reduce the need for intervention within EDs and by law enforcement. So, what do we know? What are the things that you need to take home? We need to do universal screening for better crisis management versus tailored or mental health focus. We know that the majority of suicide victims have never come close to a mental health professional or been diagnosed with a mental illness. And so the Columbia with upstream detection is really, really important. And what we know, so decoupling suicide risk detection and mental health screening. And what's happened with this science, this is another example, geographically targeted, prevention-oriented public health risk detection. We know we need, as the Federal Action Plan said, we need local data to identify neighborhood level patterns. So this was a big study that came out recently, 2025, that mapped cities and zip codes with higher concentration of at-risk individuals. They used geospatial modeling, 44,000 pediatric screens, okay, and identified neighborhood level patterns of elevated suicide risk. And that in turn helped them identify the community interventions in specific areas that were warranted in specific areas. And again, this is consistent with meeting the goals of the Federal Action Plan. So, this is really also important. Look what happens with better detection. Crisis referrals and need for acute services dramatically reduced. So this is over 9 years, 78,000 students across all counties in Ohio. And with the system impact limiting unnecessary hospitalizations by doing the Columbia and using safety plan, right? Look at the need for acute services, 0.5%. And so the Columbia is really used to address these disparities, close the suicide screening gap. As I told you, the majority of people never get close to a doctor, so we need upstream detection. In Montana, for example, which of course is like frontier, let alone anything else, they do universal screenings in the schools, okay? Almost all the students in Montana have been done. And you know what happened? With 2 screens, there was a 7-fold reduction in suicide risk, right? So juvenile justice showing that Black youth are half as likely to be screened without standardized C-SSRS. So you see Columbia updates in improving standards of care and delivery across public health at a national level, at a county level, at a state level, and then also internationally. And this is so important. Why is the Columbia the global method of detection? Because it's the first time we have evidence-based thresholds for imminent risk. We didn't know who to worry about before, so that policeman had to take everybody to the hospital. And so you see all this, saving millions of dollars, driving safer care, shorting hospital stays, and multi-million-dollar savings. And what I always say is that it's not about the millions of dollars that are being saved. It's about the harm that happens from hospitalizing people that don't need to be hospitalized. We know that. Right? When you intervene with somebody that doesn't need it, it actually shuts them down from care when they do need it. So you do see millions of dollars in savings. Oklahoma saved millions of dollars in reducing unnecessary overnights, et cetera, et cetera. And how important is this, redirecting these resources in this era of cuts that we're all dealing with? So it reduces harm, it redirects resources, and also the meaning of finally being able to identify imminent risk. What does the science tells us? That people who receive the lowest level of care in the community have better outcomes. They ask for help more often and they have better quality of life. So you can see all these things, rehospitalizations, readmissions, et cetera, get reduced across the board. And, just to say, again, the Columbia global method of detection, identifying imminent risk, just to bring some science, potency to that imminent risk is intent to act. Only 1% of people have a high risk answer on the Columbia. If you have intent to act, its risk goes up 1,400%, 600%, et cetera. And it's also the first time we have the full range of behavior. In the past, you would have been lucky if you got asked about a suicide attempt and then you missed the person who bought the gun or wrote the note. These things that only the Columbia gets at the full range. Look at this. An interrupted attempt is 4 times as predictive as an actual suicide attempt. And what our data shows us is of the 1%, 87% represent these other suicidal behaviors that we were not asking about without the Columbia, meaning without it, we would miss 9 million suicidal behaviors a year. And I also want to say this is critically important. How do we leverage technology? So this is Colorado. They mine the data very well, but you can see this 10 to 18-year-olds, 80% of them take their lives at home. So how do we get in every home and every pocket? And we do it by leveraging technology. And what we also know we need to do, so there's an app, which I'm going to show you in a second, but these things only become as impactful as they need to be if we have nationwide public health campaigns like we did with smoking and seatbelts, and then you can see 5% on the street, 5% in the natural area. I'm told that you see the Columbia sign on the ledge of the Grand Canyon, but there should not be a park, a natural area, a street, et cetera, or a home where this is not being done. And this is how the app works across all 50 states. We all have a role. Are you using this to help yourself or someone else? Are you under 18? Are you a veteran? Are you helping a veteran? And then it connects whoever is using it to their local resource based on geolocation, which is really phenomenally important. So what else is really important? The critical importance of upstream non-traditional detection and going to the risk factor, okay? Because people typically don't get close to a doctor. So what does that mean? It means the dentist. It means, the construction worker, the safety check in the morning is more than the hard hat. It's the Columbia. Look at these examples. So there is zero suicide every dental visit. In DHS, they use it in the ICE facilities. They do it in every dental visit. And you know what? They found 27% of people that had a positive score that were unique encounters. So lives that would have been potentially saved wouldn't have been potentially saved without doing this non-traditional detection. So how do we find veterans where they work, live, and thrive, right? So how do we go to the risk factors? So in New York, the idea is every state agency, transportation, agriculture, DMV. I have the honor of having somebody from Virginia, Brandy, on, who has streamlined this. In Virginia, the state agency mandates Columbia for every veteran's disability claim filing, right? And how important is that? Because people don't get to the doctor, so we have to find them in all these other ways. And you know what? Breaking down barriers that, tens and tens of thousands of veterans, 75-year-old veterans who want to do this. And look at this, changing attitudes that were thought to be unmovable, right? This is amazing. When you do suicide prevention, you give the Columbia, we can do things that we didn't think were possible and that are really, really critical. And the medical model is doesn't get us where we need to be. We know we need a public health approach, and we know we need to do this in all communities. So there was an urgent memo out of the Pentagon years ago that said we must put the Columbia in all hands because people don't get to the doctor. The Marines were the first ones to test that. Legal assistants, financial aid counselors, the things that are risk factors, they lowered suicide 22% that year, and as well as other things. So that's what your communities and communities all over the world are modeling. And it doesn't matter what we're talking about, upstream, all hands, midwives, to legal assistants. And this is what, our federal agencies say. We must move suicide prevention upstream. And I want to say that guns are really important. We know that 2/3 of gun deaths are suicides. And I always say that guy who goes up to that gun counter to buy that gun does not want to die and does not know there's help. So we put the Columbia around gun locks. And why did Parkland say this is the first thing to interrupt the pathway to violence? Because 90% of shooters have suicidal issues. So it's used as a way to divert tragedies before it's too late. And the meaning of this? The Secret Service did a report of 67 prevented attacks. And you know what they found? That they're preventable when communities ID warning signs upstream. And then, one of my final points is to continuing to break down the barriers of improved crisis detection and improved care delivery. And we know that liability is one of those major, major barriers. We don't have a perfect formula. We may never have one. So malpractice attorneys have been writing about this for well over a decade, that we have a responsibility to ask, and because it has more science than we've ever had, 600 studies, 50 predictive, 9,000 if you Google Scholar it. And look at this. When MIT had a suicide, like every university does, the Supreme Court brief wrote about it with the 1% high risk answers. So those barriers of liability have really been broken down across first responders as well. And I just wanted to say, I know my time's up. With this, every student in a school, we have apps you can get in every dorm room, every pocket, and it really ties everything together. And then I did want to just talk for one moment about workforce prevention. So their apps, and it's really saving lives. So the Department of Homeland Security has their own Columbia Protocol app. So if you're Secret Service or Border Protection, it connects to their EAPs. Guess what? ICE did not have a suicide for almost 3 years since the Columbia Protocol app. And all first responders across all states can have this customization. And it's really, very, very impactful, empowering science that reinforces doing this, in all pockets, in all hands, in every moment of crisis care delivery.
Right. Dr. Posner, thank you so much. Very comprehensive. I appreciate the time spent and appreciate the material covered. We're going to move to the roundtable, and at our roundtable at this time, we have 3 individuals who are slated to speak. We have Andrea Duarte, Sergeant Russ Iger, and Brandy Jankaitis. I'm going to ask, because we are running just a little bit behind, if you could give some very brief comments with regards to the presentation. Very comprehensive presentation. So we'll start with, if it's okay, Andrea, if you want to start.
Sure. Thank you so much, Brian. And thank you to Dr. Posner for having us join you today. It's been an honor to do this work over the past 12 years in Connecticut. We started long ago reaching out to the Columbia Lighthouse Project as part of a National Guard initiative tied to our state suicide advisory board and coalition work. And gradually through our zero suicide initiatives have been just growing and connecting with different sectors. So as you heard in Dr. Posner's presentation, so many different types of groups are taking this on or adopting the Columbia and the questioning, which really helps the communication across these different sectors and practitioners. We all have the same definitions of these different behaviors, and it just really has helped us significantly. So many different state systems have adopted it, and the entire crisis service system here. And we have lots of examples of how supportive it is to utilize in these settings. So I'll stop there in the interest of time. I don't think we can hear you, Brian.
Okay, would help if I took my mute off. Brandy, if you would go next, please. Brief comments.
Absolutely. Well, thank you, Dr. Posner, as well for the invitation. Mr. Armstrong mentioned earlier the public health approach. So that's really been how we in Virginia have integrated the Columbia into our efforts to serve military-connected citizens. So I'll talk about three key prongs: screening in direct services, screening implemented online, self-report, and then screening in training. So the direct services element for Virginia Department of Veterans Services has centered on our care coordination, veteran peer support, and the benefits claims services. So about 100 staff screening every month for military-connected citizens. They conduct over 1,000 screenings every single month. And so talk about screening to safety in action. And then there's referral protocols in place for engaging 988 Virginia, and then making sure that we do the appropriate follow-up to make sure that the safe connections were made. And one of the key partners in that process are our 40 community services boards or our public mental health centers, as far as providing any additional support that the individual might need. We also have about 60 active community grantees providing anything from surf therapy, animal therapy, comedic support, art therapy, and then a variety of clinical interventions. And they are all required to use the Columbia as part of their grant-funded operations. And then our most recent launch, Veterans Day a year ago, was the Virginia Veterans Network, which is an online resource platform with over 40,000 military-connected users, and the Columbia is inserted at the very first stage for screening when they create a profile on that online resource connection. So I'm hopeful what you're hearing is each time we integrate the Columbia for military-connected citizens here in Virginia, we increase our reach, whether it's internal in Virginia Department of Veterans Services or external online or amongst community partners. And the final element is training. We train community providers in military culture, suicide prevention, and risk screening. The Columbia is the main screening tool that we train community providers to use across the state. And Dr. Posner and team will work with us to design a e-learning training specific to Virginia for our advisor, Virginia Identify, Screen, and Refer training initiative. And I'll round out there for time. Thanks so much.
And thank you, Randy. Appreciate it so much. And Sergeant Iger, just a couple of comments, please.
Sure. So in Connecticut, in law enforcement, it's also used as a training tool for officers how to respond effectively to mental health calls for service. So we want to have the officers understand when do they have to take action and send somebody to the hospital versus when do they have discretion to call in mobile crisis, to leave a person with friends and family and have them follow up on their own, to have these choices. And so the Columbia acts as a good triage tool to determine when an officer will need to take action or when they have that discretion. And in the past, there was no tool for that, just experience on the job. But we wanted to better train officers how to respond to these situations. And what we found is in the departments who do use the Columbia, we have these reductions in use of force because we're not, throwing people in the ambulances who don't want to go and don't need to go. Of course, there are still times where you're going to get into a physical situation with somebody who needs to go, but that's much more rare. And that's what we all want. So we want to train all our officers. And our training for the Columbia comes through CIT training. If you guys are familiar with the crisis intervention training. So we're training, 50 officers a month for year after year after year on how to use the C-SSRS. So it's really bottom up. It's a really bottom up training method. And we're seeing its effectiveness in the state now.
Oh, well, thank you. And thank you, all of you, Dr. Posner, and to this wonderful group for this wonderful presentation. We appreciate the information. I'm sure there was lots of questions in the chat box or otherwise, but just thank you all for joining us today. We're going to move to the briefing room with SAMHSA, but since we still have the during government shutdown, we're going to move to our NASPID report. And for our NASPID report today, we have Jenna Schofield, who is our Senior TA and Communications Associate with NASPID. Jenna, a few comments, please.
Sims. I'm Jenna Schofield. I'm with NASPID. I'm here to give you all a teaser of a paper we have in progress on behalf of SAMHSA on addressing maternal mental health. I'm working on this paper with my colleagues Lisa Hadley and Elizabeth Hank. We'll go to the next slide. So 1 in 5 mothers are impacted by a perinatal mental health condition, yet we know that only 75% go untreated, only 25% access treatment. So why is this? A lot of the same barriers that are prevalent in the general mental health population that we all are working so hard to address every day. But with the maternal population, there is an added layer of stigma, shame, fear of CPS involvement or punitive responses, being separated from your baby and your family in order to get inpatient treatment. This causes many women to delay seeking help until they're in a severe mental health or suicidal crisis and perhaps wind up in our 988, 911, ED systems. So it's important for us to think about how our crisis systems can meet the needs of moms. I'll go to the next slide. So for the paper, we talked to states to gather information about what works. I'll highlight just a few of these strategies. Training, of course, when we think about training in maternal mental health, we tend to limit our efforts, I think, to pediatricians, to OBs, to primary care, which of course are huge, important touch points for moms. But we also need our crisis teams to have at least basic knowledge of maternal mental health issues. We should try to get our crisis clinicians a basic level of comfort in treating perinatal mental health conditions, which we know can be very different from typical mental health conditions. When our clinicians encounter a case that they do need more specialized consultation, we should work to make sure they know that they can reach out to a perinatal psychiatric consultation line. Many states operate these. There's also a national line that's available from Postpartum Support International. After I'm done speaking, I'll put a link in the chat and a few other resources to be able to access that. Maternal mental health peer support, we know can be so effective to connect with a peer that not only understands the experience of dealing with a mental illness, but the specific challenges and experience of motherhood is so valuable. And then when we're thinking through crisis prevention and follow-up care, and also, the care that we're providing in crisis stabilization settings, we really can't understate the importance of integrated care for this population, for pregnant and postpartum women in particular. We can't separate the mental and the physical. They're completely bidirectional and codependent, as they are for everyone, but particularly for this population with all the physical and hormonal changes that are happening. And then we can also think a bit about partnering with home visiting programs to connect moms with home visiting following a crisis. We know this kind of instrumental and emotional support can be so helpful in preventing future crises. And then Dr. Sims, I'll end by just saying, until we create inpatient psychiatric care systems that allow moms to continue to be with, bond with their babies if they want to, and they can do so safely, we're going to have a really hard time getting women to seek care before they reach the level of a suicidal or mental health crisis. And the paper is going to talk a lot about what we need to do to get there. So I'll hand it back to Dr. Sims, and I'll put my email in the chat. Please don't hesitate to reach out if you have any questions.
And Jenna, as always, thank you so much for this information. We want to thank NASPID for their ongoing efforts and continued efforts in this field. A lot of wonderful information. I want to quickly go over to now our next feature with my good friends Paul Galdis and Tom Becklock. If you could give us a couple of minutes on BH-SPEND.
Yeah, Brian, I know we're short on time, but the Rural Health Transformation Program is a really huge opportunity that we wanted to make sure is on everyone's radar. The submission date is 2 weeks from today, so it's getting close. But if you look at the allocation here that comes from the HR1 or One Big Beautiful Bill Act, is that it's about improving healthcare access, quality, and outcomes in rural communities. And Tom and I come from state government. Well, that's always been our focus, is improving access, quality, and outcomes. In this case, though, you're talking about $50 billion being pushed out over the next 5 years. And that averages, if you just do the math, since only states are eligible, $1 billion per state, or $200 million annually for the average allocation. Anyone that gets an approved application in place meeting the criteria is going to get a minimum of $100 million annually, since half of that allocation is based on distributing evenly among states, and then there's a prioritization done for those other states. So introducing that, Tom, probably makes sense to have you dive into the details a little. And I also put this in the chat. My ongoing concern is always behavioral health. Our mental health and substance use treatment partners often end up underrepresented in some of these discussions, which are really vital to infusing some funding that can really make a difference for these rural and frontier communities.
Yeah, Paul, as you highlighted, that application is due just 2 weeks from now. And so states are scrambling to submit those applications, but that's just step one. So if you can turn to the next slide, please. You know, there's goals that have been identified by the administration in terms of what falls under this program, also by Congress in enacting the legislation that created the funding stream. And you'll see, if you think through the lens of rural crisis services, there's several different areas under the key goals that can be advanced through that lens, right? So when you look at ways to use evidence-based outcomes in behavioral health, when you look at sustainable access and expanding access, when you look at workforce development, innovative care, all of that really looks at ways to invest in expanding crisis services in our rural areas. The grant application, which I included the information in the link for the chat, also, on the next slide, identified some specific topical areas as examples of projects that could be funded with this money over the 5 years. And that included both number 7, which is right-sizing healthcare delivery systems. So when you think about looking at creating crisis services to provide alternatives as it relates to behavioral health infrastructure. Also, number 8 speaks to specifically to supporting access for SUD and mental health services. So again, you know, states are putting together application. That's just step one. CMS will review and they'll make announcements towards the end of this year, early 2026. But then states are going to have to refine those plans, right? So if you are in this space, and I know those folks that are on this call, you're looking at opportunities to expand crisis services, particularly oftentimes rural areas get underrepresented in terms of the infrastructure that we're able to create. And so we believe this is a real opportunity that folks need to be plugged into and looking to partner with state leaders in terms of how you advance crisis services in rural America.
Well, Tom and Paul, thank you so much for that information. I apologize for having to kind of jam it together there because it's incredibly important. I'm going to now turn this over to Kristen to take us out.
Thanks so much, Brian. And thank you so much to Dr. Kelly Posner Gerstenhaber for joining us this week. It's a really grounding conversation. These protocols do remind us that it's not just about the questions, it's how we show up when we ask them. We definitely want to, as always, thank one of our headliner sponsors, AHP. This jam doesn't happen without the hard work of the behind the scenes and especially our sponsors. And we want to definitely open any sponsorships up if y'all are feeling inspired by the episodes week after week and want to help keep it jamming and keep it going. We welcome additional sponsors. We do want to introduce one of our additional sponsors, Behavioral Health Link. Thank you so much for joining the JAM family. We are so excited to bring together partners from across behavioral health to keep this conversation going strong. Next week, we have Dr. Stephen Schuler, who's going to join us in a fireside chat moderated by John Draper to talk about mental health apps, AI, and where the digital world meets human care. In 2 weeks, we have Dr. Maddie Gold, who's going to share new findings from the National Evaluation of Lifeline Services. And in 3 weeks, we will welcome Paul Galdis back, who's going to debate Dr. Joe Parks about whether states should prioritize capacity in the 3 core crisis services. You won't want to miss any of these episodes. As usual, we are really excited to have all of you here every week. Thank you so much for watching. We want you to tune in, log on, join the movement, and we will see you next week.